me inside the payer community, if you will. I'm just curious, this is just me. How are these decisions made? Is it a single payer? Is there some committee inside Aetna? Is it practice driven? You look at that practice, they're having a good result with this. How do you make that call?
Yeah, I think it varies by payer. Within Aetna, we have an evidence shop that adjudicates the evidence. We do pay attention to what bodies like NCCN say as we make our determination. It's interesting that particular committee is actually firewalled off from the coverage policy committee and the pay committee. That is, how much do we pay for this? So the evidence shop is all about evidence. But they do respect what other people say. It's done differently by different organizations.
Well, in the meantime, CMS did a 12-month review of Provenge, right? How did that review influence managed care's opinion of Provenge and other immunotherapies, if at all?
Yeah, I mean, I wasn't at Aetna then, but I will tell you that I think it probably didn't at all, for a couple reasons. I think that because CMS had already decided they were going to pay for it, and then they opened the national coverage decision, plus the FDA had approved the drug, there was already a coverage policy, and I don't think that didn't make people feel like, oh man, we got it right. No, I don't think that's how it worked. I think that there was already a coverage policy in place. Certainly if the NCD had come out and said, this is nonsense, I think probably things would have happened, right? The FDA would have said, well, you know, is it really nonsense or not? But let's just take bevacizumab and breast cancer as an example, right? So the FDA withdrew the approval, yet CMS continues to pay for it. The NCCN continues to recommend it, level 2A evidence, and I think still all payers are paying for it. There may be an exception here or there, but the national payers are paying for it.
Well, I also want to, again, look at the whole cost of treatment. It's very tempting to say, oh, here's treatment A, whatever that treatment may be, and it costs $100,000. That's a lot of money. But you have to look at treatment B, and that's going to go on for years and years and years with hospital admissions and side effect profiles and what have you. That's a lot of money too. So what is the real cost differential? Are we in a position to estimate that for, let's say, Provenge and IPI and tumor-infiltrating lymphocytes for melanoma, transduced T-cell therapy, other high-attention agents? Do we really have our arms around this yet?
Because, well, they're going to be very different. With TIL, the tumor-infiltrating lymphocytes, that's essentially a one-shot deal. It's a one-time treatment. It's not repeated. IPI is 4 doses. That's the approved regimen, 4 doses over 12 weeks. You're done. That's it. Maybe you'll get reinduced somewhere in the future, but usually not. Whereas some targeted drugs you take every day forever until you progress. And if the BRAF-MEK combination has who knows what it'll be, a 2-year median survival, that means half the patients will be on for a year or more. So that could get even more expensive, because if it's $100,000 a year and you're on for 3 years, now it's $300,000.
But leave cost out of this for a second, okay?
Why?
Because, how many drugs are in renal cell now? 6, 7 oral agents?
7.
All right, 7 drugs. I'm going to say that I suspect, and I did a lot of GU when I was in practice, I'll bet you that if you start with drug A and then give drug B, that may be different than starting with drug B and then giving drug A. However, if you talk to people who do renal cell, and I'm not trying to cast aspersions on the renal cell doctors, they will come to you and say, I intend to use every drug, every single one, as long as the patient can tolerate it and there's any reasonable likelihood. Now, is that the right thing to do? I don't know. I'll tell you what, in some cases it's futile. But we actually don't know the answer to that question.
It's a testable question.
It is a testable question. The data that is required to do that it may sound simple, but it's not so simple.
All the more reason why Aetna should be supporting that kind of research.
I'm trying, believe me. It is, so this is the heart of comparative effectiveness, right? This is the heart of comparative effectiveness. And we will come to a point where those questions are going to get answered. But the reason it's not so simple is because you have to think about comorbidities in patients. Patients with cancer, I used to tell my patients that I took care of that patients with cancer, even if they have active cancer, don't always die of cancer. Actually, a lot of time they don't die of cancer. They die of something else. So you have to think about comorbidities. You got to think about all the cost centers that enter into the question of how much does it cost to take care of a patient with cancer, and what's the timeline look like? Because as Dan said, and I would agree with him, patients who respond live longer and live better.
That's not so bad.
And that's not so bad, but there's a lesson there, right? The lesson is patients, so you want to know who those are from the get-go, and then you want to have a much more intelligent approach to the other patients.
Well, even more importantly, you want to know who isn't that patient.
Right, that's exactly right.
Because what you really want to be able to do is say, this is the patient that we should be putting on a clinical trial because these standard therapies are not going to be effective in, or that we should be thinking of another modality than this one because this is not likely to work.
Well, why don't you do this for me, Jeff? Can you